I see that folks are beginning to join. You are most welcome. This is the PrEP Learning Network webinar on PrEP for pregnant and breastfeeding women, and we are going to give it about 3 or 4 minutes for folks to join the call. All of the attendees are actually muted, so just note, I'll make a little note here in the chat box that you're welcome to provide comments in the chat box. For those who are continuing to join, don't worry, we are here. We are just giving it a little bit of time for folks to join. And we'll start in a moment or two. I see we have some old friends and new friends on the line. Thank you all for joining. We're just going to wait a few more minutes. Hi, Anita. Yes, Anita has asked to confirm that everyone is on mute. Yes, all the attendees are on mute. So the best way to communicate is through the chat line. And I think we are about ready to begin. Let's see. Should I give it 1 more minute? I'll give it 1 more minute. Okay, so this is Christine Torjussen from, excuse me, from FHI 360 and the Options Consortium, and welcome to our PrEP Learning Network session today on PrEP for pregnant and breastfeeding women. If you go to the next slide, please. Aubrey, thank you. This is the outline of our talk today, and I'll go ahead to the next slide. It just takes a moment, I guess. So today's discussion is on PrEP for pregnant and breastfeeding women, which I think most of you are aware on the call has been a big focus of the COP guidelines for this coming year. And so we are very pleased to have 3 experts on the call with us today. We have John Kanudia from the University of Washington and Kenyatta National Hospital, Lisa Noguchi from JPIGO, and Lee Fairley from WITS RHI. And together with these folks, we're going to review findings from the PREA study in Kenya that provided PrEP to pregnant and breastfeeding women. And then we're also going to talk about the situation in Lesotho and new project to develop some tools and resources to support PrEP delivery to pregnant and breastfeeding women that we hope will be useful across other countries as well. And Lee is not presenting, but is here as a content expert to help answer questions and provide input on the discussion. Next slide, please. And so all of the attendee lines are muted. We would ask that you use the chat button to ask questions or provide comments or any additional insights or materials that you have you can share this way. Please select the to all panelists and attendees so that everyone can see your questions and comments. And we do welcome, we know that we have experts who are attending on the call as well as presenting. So we do ask that you feel free to share your experiences in the chat. And we will go through 2 presentations and then have a Q&A after each one. Next slide, please. So without further ado, I'm going to turn this over to John Canudia to talk to us about the PrEP study. John, over to you. I am not hearing John. Are others hearing John?
I think he's muted. There you go.
Oh, yes. Sorry.
Okay, go ahead.
Yeah, thank you. On behalf of my co-authors and the PrEP program team, I want to thank the organizers for giving us an opportunity to share these our program data. Next slide shows that is the article where with the details about our publication. Next slide. Several studies have reported high HIV incidence among women in sub-Saharan Africa during pregnancy and after delivery. A recent meta-analysis found HIV incidence of 3.8% among pregnant and postpartum women, African women, and this rate is similar to that reported among traditional high-risk groups like female sex workers and HIV discordant couples. Increased susceptibility to HIV may be due to immunological factors or physiological changes that occur during pregnancy, but could also be due to male partner sexual behavior during this period. Also, low male partner participation in PMTCT programs means that HIV and infected women in HIV discordant relationship are unaware of their male partner's positive HIV status, and therefore they would not take precautions to protect themselves from infection. Next slide. Here we are showing results by Thompson and colleagues in a prospective per coital analysis among women with HIV-infected partners, where they found increased risk of HIV acquisition throughout pregnancy and during postpartum period. Next slide, please. Next slide, please. Women who acquire HIV during pregnancy or while breastfeeding have an increased risk of transmitting the virus to their infants due to the high viral load associated with acute HIV infection, absence of HIV immune responses, and also that unlike women with chronic HIV, they do not receive either maternal or infant antiretrovirus. It is estimated that acute maternal HIV infection during pregnancy or while breastfeeding would account for almost 30% of vertical HIV infection. Therefore, initiatives promoting primary infection for women, such as PrEP, are critical to ensure that HIV and infected women at substantial risk of HIV remain uninfected, and also to support efforts to eliminate mother-to-child transmission of HIV. Next slide. PrEP is an attractive HIV prevention strategy for pregnant women because it allows let's continue. Yes, it allows women to be in charge of her HIV prevention, does not require negotiation with her male partner, and is safe during pregnancy. MCH clinics, continue. MCH clinics offer an existing HIV prevention platform for PrEP delivery with several advantages. One, the access is high. For example, in Kenya, more than 90% of women make at least one antenatal care visit. And this is similar. This happens also in other other areas where there is a high HIV prevalence and incidence. Also, picking drugs from MCH clinic may be less stigmatizing for HIV and infected women. Next slide, please. However, there are unanswered questions regarding PrEP in pregnancy and postpartum. One, it's unclear whether pregnant and breastfeeding women recognize risks for HIV, which pregnant, whether women would accept PrEP, next, whether gastrointestinal side effects, which are common in pregnancy, would be exacerbated with use of PrEP, and whether women would adhere to PrEP. Next. Our objective was to evaluate PrEP uptake and identify correlates of initiation and continuation among pregnant and postpartum women offered PrEP within routine MCH clinics. Next slide, please. The program was implemented in 16 maternal child health clinics in Kisumu County in Western Kenya, highlighted in red. And the reason for choice of Kisumu is because it's one of the areas where there is high prevalence and also high HIV incidence in the country. We started by developing system for PrEP delivery within the MCH. Thereafter, women who are seeking care in this, who are seeking antenatal postnatal clinic in these clinics were screened for behavioral risk factors, their willingness to consider PrEP in line with the Kenyan National PrEP guidelines, and those women who were willing to initiate and were eligible were dispensed PrEP at the same visit within MCH clinics. Next slide. We conducted 9,376 assessments among pregnant and postpartum women visiting the 16 facilities. And of these, 52% of the women were pregnant and 48% were postpartum. Overall, 2030, that is 21% of women initiated PrEP. Next slide, please. The median age of women assessed for PrEP was 24 years. 53% were 24 years or younger. Majority were married. Partner HIV status was unknown in 34%. And among pregnant clients, the median gestation age was 26 weeks, and 45% were attending their first antenatal clinic visit. Next slide, please. We found that women who are less than 24 years or younger, who had partners living with HIV or partners of unknown HIV status, were more likely to initiate PrEP. We also found that women who were diagnosed with STI, had been forced to have sex, or had experienced intimate partner violence in the previous 6 months were also more likely to initiate PrEP. Next slide. Among women with risk factors for HIV, the most frequently reported reason for not initiating PrEP was need to consult partner and perception that their risk was low. Fear of intimate partner violence was reported by 14.4% of women. And among pregnant women, only 1.4% reported fear of effects of PrEP on the unborn baby as a reason for not initiating PrEP. Next slide, please. PrEP continuation rates were modest. We evaluated at 1, 3, and 6 months, and we found that at 1 month, continuation rates were 39%, 3 months was 22%, and 12% at 6 months. We found that women whose partner was HIV positive were more likely to continue PrEP, than those with the partners of unknown status or HIV negative partner. Next slide. the most common reason for discontinuing PrEP categories was experience of side effects reported by 25.1%. Then we had about 10.5% of women who reported they were afraid of intimate partner violence, and there were very few who discontinued because of fear of effects on their baby. In our program, next slide. In our program, we did not, there were no incident HIV infection reported among women on PrEP. Next slide, please. So in conclusion, approximately 1 in 5 of pregnant and postpartum women initiated PrEP in this large implementation program. Women who initiated PrEP were more frequently younger and likely to have risk factors, HIV risk factors, for women when compared to women who did not initiate. Few women reported fear of intimate partner violence or effects of PrEP on the unborn baby as a reason for not initiating PrEP. Overall, approximately a third of women did not know the HIV status of their male partners. Next slide. Implications. From our program, we found that a substantial proportion of women seeking antenatal or postnatal care had HIV risk factors that placed them at risk for HIV, and these women were willing to initiate PrEP when offered, indicating that routine MCH clinic can be an important platform for PrEP delivery. Nevertheless, we found that knowledge of male partner HIV status remains low, and there is need for strategies to optimize partner HIV testing, because PrEP can be an attractive prevention option for women with partners of unknown status who find it difficult to negotiate condom use. And lastly, we really were grateful to all the participants who agreed to participate, who were offered PrEP or participated in this program. Our program nurses, the Kenya Ministry of Health, and the Kisumu County government, and our funding, which was from the United States Department of State as part of the Dreams Innovation Challenge, and was managed by the JSI Research Training Institute. Thank you.
That was wonderful. Thank you so much, John. We have a number of questions that have come through, and so I'd like, John, you're welcome to answer, and then I'm also welcome Lisa or Lee to weigh in as well. So I have there are a few questions that are specific to the PREA study. So first of all, Jason Reed is asking if you could clarify on the 3 and 6 month continuation estimates, what was the denominator that you used? Did you use all women enrolled for each of those, or did you just use the number? I should just read his question. Is the 3 month percentage using a denominator of all women enrolled, or just the number that returned at month 1? Same question for the 6 month percentage. Is the denominator all women enrolled, or only the number that returned at 3 months? We could go to that slide, that might help. Aubrey?
Yes.
So I think this question is your denominator changing every month, or are you using the original number enrolled at every month?
We can go to the next question as I confirm how I did this.
Sure, no problem. Okay, they're wondering if you looked at whether women who discontinued PrEP then might have started it again later.
we were not able to capture, we don't know whether they may have restarted at a different time point or at a different facility. We did not have that data from the
It is
the way the program.
You were breaking up a bit, but I understood that you were not able to track that the restarts.
Yes, we would not be able to know whether the women started, but we know from what we presented for this data, we were looking at first-time screeners, and those women are the ones we followed up. We have not looked at the data to see whether there were people who came in and got out. Probably that's something that would be interesting to look at.
Yes, it would be interesting to see. We do see, I think I've seen rates as around 25% of restarts in some other PrEP programs. And so it would be interesting to see if that is similar among pregnant breastfeeding women. And also just to note that we had a previous session last year, Learning Network session, on how to measure continuation in some unique ways, including how to look at restarts. And we will have a follow-up session on that later this year. We just haven't scheduled the exact date yet. But those resources are available on the Learning Network webpage on PrEP Watch. I have another question from Grace. Were there any efforts to engage partners of pregnant and breastfeeding women to address potential IPV or social harm? And were there any cases of IPV reported?
Yes, we had collaborated with the Kisumu County. They have a referral facility for women who would get IPV. But my recollection, we did not have a case of any woman who had IPV and required to be referred there, who had IPV because of use of PrEP. But we did have arrangement. We had taken that into account so that we could be able to we could be able to refer in case a case came. But we did have assessments, and we asked at the initiation and also subsequently when they came for refill.
Mwanza is asking a question of whether you had to adjust your national risk screening tools, and in particular the behavioral questions for this population.
We adapted the tool as was, and that's what we used. We didn't have to make any adjustments. So we actually wanted to use the tool because that around that time is also when the national program was rolling out. So it was also an opportunity to see how well that tool would work. As a program, we wanted to have as fewer changes, or to make as few changes as possible to what would happen routinely in other settings. So we used the tool as was developed. We only customized it, put our logos because of the way we are collecting data.
Christine, could I ask a question related to that? Sorry.
Please.
It's Lee. But just to ask John, and this is really fantastic work. Thank you so much. But so in the women that actually took oral PrEP, we've got data on on their risk perception. But in the women who didn't, was their perception of their risk kind of deemed correct? I mean, or did they have similar risk factors, as in a known HIV positive partner or unknown status? Because it seems that the women who took PrEP were very good at perceiving their risk, but I'm just curious about the group who didn't take up PrEP. Thanks.
Overall, we found that women are able to assess their risk well. There was alignment, and to a large extent, there was alignment that actually women could be able to generally overall be able to say when they were at risk. But however, we also found, and I think that's an ongoing analysis, where we were looking at some women who, although they reported they didn't perceive themselves at risk, yet they had those risk factors. And that becomes an issue for us in terms of counseling, that when you're talking to the women, those factors that may put them at risk should also come out quite clearly. But generally, there was good alignment between the women who would want to put on PrEP and the women who are put on PrEP.
Great, thanks.
We have some additional questions. Chantel is asking if you had any refusal to initiate due to the association of PrEP with ART. So I think this is getting at the issue of stigma, and if that came up in your study.
We not that women refused to use PrEP, but it required a lot of explanation. What is PrEP? They had to be informed that it is an antiretroviral drug, and that unlike when they take it because they are infected, in this case, they are taking it to prevent infection. We made that very explicit when we are talking to them so that they are aware. Because in any case, it has been seen, some of them have also relatives who are taking those drugs, so they had seen them and they were concerned. And those are some of the issues that when we were having some discussions with them, they would come up, that yes, they feel uncomfortable to some extent carrying a drug which is an ARV, and they also felt that because they are given a number of tablets like 30, they go making a lot of noise. To them, it seemed to be, they make more noise than other drugs, probably just psychologically because they are trying to deal with having to use those drugs.
One question I had actually, John, is that I didn't see mention of whether or not, if it was a first pregnancy, was a woman less likely to take up PrEP than if it was a subsequent pregnancy?
We didn't find, the factors we put are the ones that were significant, but like whether it was a subsequent pregnancy or not, were not significant. That's why
it's interesting.
We have not included, yes.
Yeah. Nita is asking how does the uptake, were you able to compare the uptake of PrEP among women in the general population to your study population, and how do they compare?
Okay, we didn't have data about uptake in the general population. We must add that we were among the first group to initiate or to give PrEP to the general population, in the sense that we were offering it at MCH to all pregnant women. Previously, PrEP was only available in CCC, and to those women whose HIV positive, that is in a relationship. The Kenya Ministry of Health had just rolled out guidelines and rolled out PrEP. So we were also developing system on how this would be done for the general population. So we don't really have that data for comparison from our sites.
Okay. Chisal asked a question, and it's kind of related to another question I had, which is, how is the sustainability guaranteed in PrEP continuation, considering that your study is silent on the role of government? So I think that might be even a broader question, like how does the PREA work and the sites that you use fit within the national rollout overall? And to what extent is PrEP provided right now for pregnant and breastfeeding women in Kenya? And how will this work help move that forward?
Yeah, So in terms of how it moves forward, as I said, we were pioneering, we were trying this. The ministry then had rolled out the guidelines, which had included pregnant and breastfeeding women if there was substantial risk as candidates who can receive PrEP. But there were no structures which had been put in place because this was very early on. So in a way, what we were doing was to go to MCH, see how this could work, develop flow, see what challenges would happen when PrEP is delivered in MCH, even see whether it is really feasible, it could work. So we found that it could work. We trained the nurses we were working with, especially in the later part. We trained the MCH staff in the later part of the program so that we can hand over the program to them and they continue. And anecdotally, because we have not evaluated systematically, we know that PrEP still is being dispensed in MCH. We trained the staff and also it was embraced. Actually, we had a lot of support from both the national government and the Kisumu County government, because in Kenya we are working with the devolved health system. So before the program came to an end, we had the stakeholders meetings with the county government officials, with the PrEP implementing partners, and also staff from the facilities to think about or to strategize on how the work would continue being implemented. And there were really very good discussion, and there was a lot of people are positive about making it happen. So to a large extent, I would think that the government, especially the county government where the implementation was happening, gave adequate support. And even in terms of follow-up and ensuring that this happens, even in terms of provision of commodities and the reporting tools, because all those were from the government. So I would say that although we have not systematically evaluated, but there is PrEP delivery in the country. I may not know exactly what numbers. We may not have the same numbers as we were seeing in the brief period that our program was implemented, because we didn't have dedicated nurses. But we also strategized on different ways of ensuring this happening. One of them was that the negative women get some post-test counseling, that they are negative and they need to maintain their negative status. And that can be an opportunity where even their risk is assessed, and those who require PrEP are referred for PrEP. So it can actually fit within even the MCH system as they are right now.
Thank you, John. I'm looking at the time. I want to ask one more question because it came up a few times around STIs, and then we'll move on to Lisa's presentation. And if we have time at the end, we can come back more to these questions. But several people asked about, STI prevalence in this population, and did you see any increases in STIs? And also, how did you handle partner notification?
We asked about STIs, mainly we did syphilis testing, and the prevalence of syphilis in the county is about 2%. But that's the only STI that is tested routinely. The others are managed syndromically, which has its own limitation. We did not have a partner notification as part of, for STIs as part of our initiative, but we did have a partner HIV testing, in the sense that we offered the HIV self-testing. Currently, we are planning to roll out another study probably in the next 2 months or so, where we're also going to do STI testing. So we'll have a better sense because we'll do point of care testing for STI. So we'll have a better sense of what are the actual prevalence of the other STIs besides syphilis.
Thank you. And also, John, we'll give you an opportunity to answer some of these questions in the resource sheet that we send out, so you will be able to provide some more of the data. Thank you very much, John. And we're going to move on now to Lisa Noguchi's presentation, and then we will have some additional time for conversation after that. Lisa, over to you. Next slide, please.
Thank you. Can you hear me, Christine?
Yes.
Great, thank you. Thank you so much. And thank you to Dr. Knuthia and to all of you for joining us today. And thank you, Dr. Knuthia, for really just a great presentation. It's some fantastic work that you all have done. So I'd like to start really briefly with a very short story. Nearly 20 years ago, I was caring for a woman in my antenatal care practice here in the US. And this was a woman who was pregnant for the very first time, and she knew that she was at risk for HIV infection, but she was not in a partnership where condom use could be negotiated. And unfortunately, at that time, we had nothing else to offer her for protection, and she did become infected with HIV as well as syphilis, and that memory has stuck with me for many, many years. But today, we can offer pregnant and breastfeeding women a powerful and safe tool for protection from HIV infection in the form of oral PrEP. Next slide. So I'll start by giving you a quick introduction to CHOICE, which is a one-year collaboration funded by USAID in partnership with PEPFAR via OHA's new 5-year competitively awarded mechanisms, EPIC and RISE. Our objective in CHOICE is to increase awareness, expand access, build capacity, and support effective use of ARV-based HIV prevention options in sub-Saharan Africa. So PrEP, and hopefully someday also the Dipivirine ring. Next slide. Next slide. Oh, sorry, previous slide. And this objective is well in line with the new COP guidance that clearly calls for prioritizing scaling up PrEP rollout for populations of substantial risk of HIV infection, including pregnant and breastfeeding women. However, there are few tools that are targeted to PrEP service delivery for this population. So one of our CHOICE activities aims to fill this gap. Next slide. So our objectives are to review the contextual factors for PrEP use among pregnant and breastfeeding women in Lesotho, and to review some planned activities related to development of a suite of materials to support PrEP service delivery catered to the needs of pregnant and breastfeeding women. And we'll talk a little bit about the Lesotho context, but with ultimately, we are aiming for our new tools to have flexibility for adaptation to other settings in the region. Next slide. And I just wanted to note that I recently saw this beautiful picture of Her Majesty the Queen speaking with a lot of determination about the importance of exclusive breastfeeding to the health of children in Lesotho, and I was very happy to include that image here. Next slide. So to move to the Lesotho context, approximately 340,000 people estimated to be living with HIV in 2018 in Lesotho, with nearly 13,000 of those newly infected. And as in many other settings, women are disproportionately impacted by HIV, comprising more than half of adults living with HIV and accounting for nearly double the new infections when you compare young women to young men. Next slide. And while the fertility rate has been declining in recent years, women may still be pregnant for a substantial proportion of their reproductive years, with the average still over 3 births per woman as of 2016. Next slide. Similarly, a high proportion of children in Lesotho are breastfed, fortunately. The median duration of breastfeeding is about 21 months, although exclusive breastfeeding is still less than a month due to early introduction of other foods. And as I've been saying for many years now, as have many of you all on this webinar today, pregnant and breastfeeding women are not a special population of women at risk. The pregnancy and breastfeeding are phases of increased HIV risk among this population that we aim to serve, a population already in need of safe, acceptable, and effective strategies for HIV prevention. Next slide. So what about routine care during pregnancy and postpartum? So fortunately in Lesotho, antenatal care coverage is relatively high for the region, although as in many other countries, effective coverage for postnatal care appears to lag behind a bit. But you can start to see how this provides a potential entryway for service delivery integration. Next slide. So what do the current national guidelines say with regard to pregnant and breastfeeding women? These populations should be provided with provider-initiated testing and counseling with appropriate linkage and retention to prevention, care, and treatment services needed to promote mother's health and prevent new pediatric infections. They should receive HIV testing services integrated into routine care with appropriate repeat testing as indicated here. Next slide. So fortunately, the existing PrEP policy does not prohibit inclusion of pregnant and breastfeeding women, and some work has already been done to support introduction of PrEP use for pregnant and breastfeeding women, although there is still some work to be done in the policy and guideline area. Next slide. So we do see a potential entry point here for integration of PrEP services, provided that potential challenges in service integration can be overcome. We know that antenatal care and postnatal care settings for service delivery are often challenged by provider shortages, commodity shortages, et cetera. And so we'll have to approach this, I think, very carefully. We do have some good examples of integration in the context of diagnosis and treatment. Next slide. And lastly, before we move on to the development of new tools that we're looking to do in the CHOICE project, I wanted to highlight here this excellent framework published by Dr. Davies and Dr. Heffron, which shows a range of potential barriers to PrEP use during periconception and pregnancy that we all need to consider moving forward. And of special note, I think, here is the fact that these same issues are often relevant to PrEP use by breastfeeding women as well. Next slide. So I'll move on to our planned materials development. Next slide. So our plan is to start with the development of some clinical guidelines with the goal of drafting materials from a broad range of stakeholders. And optimally, these guidelines will include evidence for need, information on safety and efficacy, how to approach PrEP provision and counseling, the goals of PrEP delivery, managing side effects, clinical follow-up, clinical monitoring, integration into ANC and PNC services, and support for continuation, documentation, and data use. Next slide. And we've also learned of substantial interest in training resources, so we will develop those as well. These materials may include a facilitator's guide, a sample training agenda, some slide sets, some job aids, potentially some exercises and discussion exercises for groups that are learning PrEP delivery for pregnant and breastfeeding women, some initial guidance on quality improvement, such as some sample indicators, and hopefully some support for development of a rollout plan as well. Next slide. And lastly, perhaps the most challenging will be development of some tools to support pregnancy and birth outcome surveillance as a way to approach the continued collection of safety data associated with PrEP exposure in pregnancy, as is currently recommended by WHO. But this is outside the context of a clinical trial. And we know that routine data collection systems may be good at collecting and aggregating certain types of MNH data, but not necessarily the same sorts of outcomes that we would want to track in a surveillance program. So these materials might include some operational guidance, some data collection tools, data summary sheets, potential frameworks for registers, and some guidance on how to look at these data, optimally in collaboration, I think, with local investigators, local universities, local public health officials, etc. Next slide. So when we say a broad range of stakeholders, we're hoping to include those here, potentially others as well, including, of course, the Ministry of Health, the Ministry of Local Government and Chieftainship, the National AIDS Council, the many professional associations of doctors, midwives, and nurses, the HIV and MCH working groups, and WHO in terms of WHO headquarters and WHO local office as well. Next slide. And here's our ambitious timeline. This is a one-year project that we have in choice, so the timeline is relatively assertive, I would say. We are working with our local team in Lesotho very soon, hopefully, to start working on some stakeholder consultation and the first drafts of materials, which are already underway. We'll move into some pilot testing, pilot training, some revisions, and also development of the additional materials, some polishing and dissemination, we hope, before the end of the year. Next slide. So how will we measure success? So starting, I think, with the end in mind, we want to land with very clinically sound and client-centered materials. We want to include the perspectives of providers very much and focus both on the provision and the experience of care, which we know is important for retaining women and families in clinical care and facilities. We're hoping for extensive inputs from the region to support a strong integrated service delivery model that could be adapted for other settings. And we've proposed an evaluation, we hope, for the first 6 months of 2021. Next slide. And so lastly, I want to say thank you for the generous support from our funders. Thank you to my co-presenter, Dr. Knuthia, and to Christine for guiding us, and to all of you for joining.
Thank you, Lisa. So as folks will see, this is sort of this was a scoping of the situation in Lesotho and some plans to develop tools, because this seems to be a gap in the field. How can we move forward with PrEP for pregnant breastfeeding women if we don't have the policy, an enabling policy environment, and implementation tools and ability to integrate in service delivery? So that's the goal here. I do see a question from Chisala that has come through. So I'll read it out loud. Noting that your study setting has high ANC coverage, where is the gap to warrant provision of PrEP in this subpopulation? What is the potential conflict between epidemiological and clinical evidence that would affect policy? I don't know, Lisa, if you want to take a stab at that, or if you want me to comment, I can as well.
So I think the first thing to comment on is that, we actually don't, this is not in the context of a study. This really is implementation work, just focusing on tool development, optimally with a lot of input from local stakeholders, as I mentioned. So in terms of the gap to warrant provision of PrEP, I think we know just from the epidemiologic evidence that this is a population at high risk, and that PrEP currently isn't extensively delivered in routine ANC settings. And so I think that's the gap that we're trying to focus on. In terms of potential conflict, I think we're hoping that the tools that we set up can help collect some data on surveillance, but Christine, if you want to comment as well, I just want to make sure I'm not misunderstanding the question.
Yeah, I think that this the main point I wanted to make was the same as yours, that ANC coverage alone is not enough, because this population is at such high risk of infection that providing prevention options is essential. So that was my main comment.
But if we've misunderstood the question, please do clarify.
And Chisala had some questions in the previous session that we didn't quite get to as well. I'll try to see if I can go back to it. So, and John, you might, or Lee, you might want to jump in on this as well. So one of the earlier questions was, with the current challenges reported among pregnant and breastfeeding women who refuse to take malaria, anemia, family planning drugs, including, I'm not sure what that word is, do you think an intervention to improve PrEP uptake should be based on an ecological model to explain hidden social cultural confounders that are deeply embedded in the social fabric of community domestic politics that influence health promotions and budgets and community support? It's a very long question, but I don't know if I think what we're getting at is sort of, what is the bigger picture here of the challenges that pregnant and breastfeeding women face, and how can we more broadly address those in our efforts as we roll out PrEP. That's going to be my summary, Chisala. I hope I captured it.
And Christine, maybe it would be helpful also while John is unmuting to go back to the slide of Renee's that shows that framework addressing sort of the big picture of barriers to use. I think John's still on.
Is this the correct one?
Yes, thank you.
Okay.
Thanks, Aubrey. John, do you want to go ahead?
Yeah, I would say that I would look. I'm looking at it at several points. On one hand, you do need to have the intervention available. So getting PrEP available for pregnant and breastfeeding women is an important intervention at the beginning. But I do agree that after you make it available, then you also have to also think of how do you ensure that the intervention is taken up by the women who need it and for the duration when they need it. And I think those are some of the challenges we had with our data, because yes, we may see low discontinuation. I mean, we can see, not low, we see the discontinuation, but we may not know specifically why they discontinued, because we know there are some changes which occur during pregnancy, like the frequency of sexual activity reduces. So if the woman is not sexually active, does she still need to continue using PrEP? Probably not. We offered self-testing. If the woman went and tested her partner, found that she had her partner was HIV and infected, then she probably does not need to continue using PrEP if the partner does not have any other partners. So I think what we have presented, we may not necessarily be able to interpret it and say that it necessarily says there is a problem, because there are many aspects that need to be better understood. But I do agree that we, in the context of delivery, we also have to think about how do we promote use and how do we encourage the women to continue using. And this may as well involve very different initiatives. And I think all of them are required. I think with HIV prevention and even management, it's accepted that is not one it's not one magic bullet. It's a combination of initiative. You need this and everything else to prevent these infections.
Yeah, I would echo what Dr. Knuthia said, and also just really point out how much focus we all will need to have on PrEP continuation, which is not just a challenge among pregnant and breastfeeding women, but a challenge among I think many PrEP clients overall, and the extent to which we can address the specific needs of pregnant and breastfeeding women in service delivery and how they want their PrEP delivered, I think will be very helpful going forward.
Lisa and John, can I ask, sort of related, I guess, but just really around whether you've had any experience of adherence support tools or mechanisms, because obviously, I think as John alluded to, quite a number of women sort of fall out of taking PrEP, and that may be appropriate, but it may also not. And I know certainly there's a lot of discussion about the implementation of sort of postpartum clubs or pregnancy clubs, or that type of intervention. And I wondered if there had been any experience in either of your either research or programmatically that could guide programs.
Yes, one of the initiatives we came up with was a use of SMS messaging. And we did find that actually the women who received SMS were more likely to continue. But again, this was done within the context of a program which was running. So, and rather than, like an RCT. So yes, the data is encouraging, but we see it gives us ways that things could be done differently. But without it being done in a systematic way, we can't necessarily say that definitely that is one way. But that is one strategy that we adopted. Also, I think the quality of counseling came up, and we also found that, I mean, with time, people are more comfortable, because at the beginning, PrEP was new. I mean, it had just appeared in papers. People didn't know much about it. We believe that as the awareness, as PrEP becomes more available, and over time, because people come to internalize issues of PrEP, then it would be easier to have a better, I mean, to have higher continuation rates.
Thank you, John. I actually wanted to take a moment and ask Lee if she could share a bit of the situation in South Africa. To what extent is PrEP being provided to pregnant and breastfeeding women?
So at the moment, I think there is a guideline revision that's being discussed, but at the moment there's not blanket rollouts of oral PrEP in pregnant and breastfeeding women. And I think one of the main concerns really has been around a lack of data. I think there's a lot of tenofovir data on women and infants exposed in the antiretroviral for treatment context, but less for PrEP, although one notes that there really are a number of studies that are either ongoing at the moment or will be completing in the next couple of years, and certainly there should be more data available then. So at the moment in South Africa, it's really around risk, and obviously on an individual basis, if women perceive their risk to be very high, then those women would be prioritized for PrEP. So at the moment, it's a slightly individualized approach rather than a sort of large-scale rollout.
Thanks, Lee. And for those who don't know on the phone, there are several clinical trials underway, including in South Africa, and with Lee and Lisa leading them, that are trying to generate more safety data on PrEP in pregnancy and breastfeeding. So.
And maybe just to add, Christine, sorry, I guess one of the major concerns is the low drug levels in the second and third trimester, and I think that certainly papers presented previously at CROI, and I think there's still uncertainty as to how this can be interpreted, although it's extremely reassuring to then of course see John's data where it doesn't seem to make a difference even if the levels are low, because in fact in their study no women were infected with HIV, which is really reassuring.
And yes. Christine, I'll add too that in terms of tools or strategies to support continuation or adherence, we do have some examples from other research. I think as Lee was mentioning, pregnancy clubs, in the context of group-based antenatal care, we have seen some really good improvements in uptake of other preventive behaviors with regard to, say, malaria prophylaxis. We've seen better uptake of malaria prophylaxis in countries that use that with group-based antenatal care, and also with uptake of postpartum family planning and continuation of postpartum family planning in the women who are engaged in group-based care. So I think that's an area for further research.
Yes, agreed. So I think we should pull whatever resources we do have on that and make those available to this group. It does raise a question about sort of, do we, at this point, do we have a sense, and maybe John, you can answer to this, is there a difference in PrEP use and continuation during pregnancy versus the breastfeeding period?
I believe we had seen some slight change where adherence was a bit better, but I would need to confirm that. I could just check the data to be certain that I'm actually accurate. But we are right now conducting a randomized clinic. A cluster randomized clinical trial where we are evaluating different models of PrEP counseling and initiation, where one group of women are offered PrEP and vis-a-vis a targeted approach. And this being a research, more of research, then we are going to have a better understanding of even the issues of adherence and everything. So far, we have a follow-up retention rate of over 90%. So we don't have a lot of discontinuation. So we'll have better understanding of what really happens and why people stop or continue. We'll have a better understanding of that when we are done with the study later in the year and we analyze the data.
Thank you, John. Before we close, I just want to see if our panelists have any final comments or that they'd like to make or respond to any of the questions we didn't get to.
No, I think just to say thanks to all of you for joining. I really very hopeful about this work moving forward. We're very interested, I think, in inputs from the region. And so please do let us know if you have thoughts about the service delivery materials and how they might be more useful in your context.
Thanks, Lisa.
And maybe just to say, I think it's a really exciting time for the field because people are actively engaging in this type of work with pregnant and breastfeeding women. And, unless we actually do the work, we're not going to be able to implement well ultimately. So yeah, I think it's just fantastic work that everybody's doing.
Thank you, Lee. I will mention that, so I know Chisala raised a question or made a comment about thinking about PrEP in the context of all the social, cultural, religious barriers and using ground-up approaches and engaging the community. And I am aware that there is some data that's a manuscript will be coming out shortly that is on this issue of, what are some of those cultural considerations around pregnancy. There was some qualitative work done related to the Microbicide Trials Network studies. And so there will be some data coming out that talks about what communities in several sub-Saharan African countries are saying about those considerations in this time of life. I do want to move on to the next slide. Aubrey. We keep going, one more, there we go. So we are having another webinar on March 26th on how to address intimate partner violence with PrEP services, which was also a big issue in the COP. And we just put the dates of the future webinars for you there, although we are still working out the details of which topic will be presented when. I want to really thank our speakers and panelists for today. And then I ask that you and all of you for participating. And if you would please respond to the survey. This is the resource sheet. We will have all of this posted on the website, and here's the link. And then if you could go to the survey, Aubrey, since we are over time, and I wish everyone a wonderful day. Thank you.
Thank you.
Thank you.
Thanks.